So these classic cutaneous findings are commonly seen in dermatomyositis, but before we talk about them, what is this disease? Dermatomyositis is an autoimmune condition that causes inflammatory myopathy in the proximal muscles of the upper and the lower extremities, making the patient present with a progressive muscle weakness, in addition to many other manifestations that can be divided into systemic manifestations and cutaneous ones. The patient may come with a fever, malaise, fatigue, and the most important one, which is the muscle weakness that is slowly progressive, symmetrical, proximal in the upper and the lower extremities, making the patient suffering from difficulty of getting up from a seated position. In addition to this, the patient can complain from abdominal pain and may develop dysphagia due to the involvement of the striated muscles of the upper pharynx. Now, what about the cutaneous manifestations? The classic ones are the heliotrope rash, the gutters, papules, and the Schawel sign. All are pathognomic for dermatomyositis and all are violaceous poikiloderma but over various regions of the body. So how they look like, this is the first one, which is the heliotrope rash over the eyelids, and this is the gutters papules, which is an erythematous rash over the dorsum of the hand, and the final one, which is the Schawel sign or the V sign, erythematous rash over the shoulder and the upper chest. Also, the patient can complain of rhinoids phenomena, as you can see here. Nail changes also, it's possible. And the most important thing to be mentioned that in over 15% of cases, dermatomyositis is a paraneoplastic syndrome of malignancy. And this is very important because we have to do a regular age-appropriate cancer screening, okay? This is essential in these patients. So what are the investigations we do when we suspect dermatomyositis? The first, we do a muscle enzymes, the most important one, which is a CBK, a creatine phosphokinase, that will be elevated more than 10 times the normal upper limit. Also, the anti-nuclear antibody will be positive oftenly, but it's not specific. In addition, we're gonna to do an autoantibodies that are responsible for these manifestations. And the most important test is to do a muscle biopsy that we usually don't do it to see the mononuclear infiltrate around the atrophied and the necrotic muscle cells. So what is the management? The initial treatment is a high dose of systemic glucocorticoids in addition to steroid-sparing agents such as azathioprine or methotrexate. And don't forget to do a screening for each patient for malignancy. We can conclude that when the patient has the classic cutaneous findings that we have talked about with proximal muscle weakness, then the patient mostly has dermatomyositis. And don't forget to do a screening for malignancy